number 9, the London Pain Clinic in Harley Street, to talk to one of their doctors, Dr. Ivan Ramos. So, Dr. Ramos, what are the symptoms of a painful knee?
Primarily pain. Pain can come in different shapes and forms, and it can affect at different times, or it can affect continuously. The knee has very specific characteristics that are individual to the knee joint, and by that I mean a very rich nerve supply. So a knee can be extremely painful even with small trauma or with small injury or with small degree of damage. The second peculiarity of the knee joint, which also increases the degree of painful symptoms that come from it, is the fact that the knee joint has receptors inside the capsule for morphine. Morphine is a painkiller drug that works on certain chemicals within the nerve system, and those chemicals are called receptors, which are gates that trigger certain chemical reactions when they are blocked or active. And the knee joint has that type of receptors where, should we be in a position to be able to inject morphine inside the knee joint, will get pain relief. So those two peculiarities, the increased nerve tissue in the capsule of the knee joint and on the inside of the knee joint, together with the presence of receptors that can potentially be directly related with transmission of pain, make the knee joint a very painful area. All the symptoms that come with the pain is a reduction in the movement. Contrary to the hip joint that moves in all directions, the knee joint is very much restricted to one movement. It can either extend or bend. Unfortunately, a knee that's painful can often be unable to fully extend. And walking on a knee that is partially bent is extremely disabling. First of all, it's very painful. Second, it will refer with time pain to the ankle, to the hip, and to the back, because the structure of the leg itself is abnormal, and the normal design of the leg to be able to stand the weight of the body in a perfectly aligned position has been disturbed. So muscles will need to be recruited to support the bones of the leg in the standing position when the knee is partially bent, and with time that will create significant levels of pain in areas other than the knee. Overall, the combination of the pain with the reduction of movements will bring some form of disability. And the concept of disability effectively relates to the fact that the person who suffers from disabling levels of pain or from severe levels of pain will eventually have less ability to do the tasks and the activities they want to do. And these may be sporting activities, these may be leisure activities, walking, trekking, swimming, playing sports, or simply be able to get to and back from work, be able to do the school run, be able to play with their children or with their grandchildren. So it can significantly diminish the quality of life. People who have a significantly reduced quality of life are likely to develop psychological problems as a consequence of that. Everybody, or almost everybody, can deal with a period of time that we know when the end will be, where a certain degree of inability to do something is present. The difficulty is to deal with that disability when we don't know when the end is going to be. And that can drag a lot of people down So we have to explore all those symptoms in order to establish an accurate description of how the symptoms of pain and the other associated elements of it are affecting a person overall. A few months ago I mentioned that the hip joint has a very rich nerve supply and also has receptors where potentially we could manipulate pain transmission with morphine. The relevance of that is that the proportion of patients who complain of knee pain with a combination of mechanical and nerve symptoms is relatively high compared to other joints. So specifically for the knee pain, certain interventions that try to modulate the nerve system that supplies the knee itself can be very beneficial. This applies both in a knee that has been operated, in a knee that has been replaced, or in a knee where a replacement or surgery has never taken place. Have to bear in mind that a knee replacement is a fairly traumatic operation that involves a significant amount of bone cutting. So potentially that can lead to neuropathic pain. And in fact, compared to other joints in the body that are replaced, the success rates from knee replacements are not as good, although they are the gold standard of treatment for osteoarthritic pain. The success rates are probably not as good as one would expect from, for instance, a hip replacement. So overall, the symptoms would be mechanical pain, neuropathic pain of a variable degree, together with reduction in the quality of life, physical and sleeping ability, as well as some form of disability, and to a small group of patients, some psychological disturbance because of the way the symptoms are affecting them on a day-to-day living.
And how do you investigate knee pain?
As with most problems that affect overall the human being, careful history is paramount. We have to listen to what you as a patient tells us. Only you know how much pain you have and what effect this pain is having on you. So we have to accept that information that will lead us to some form of approximate diagnosis of what type of pain you have and where that pain might be coming from. We need to supplement this information with the findings from touching, feeling, moving your knee, so from a physical examination. So we do an examination of your knee, looking into fluid inside the knee, looking into stability of the knee joint that may point more towards a surgical problem, more towards a musculoskeletal problem. We need to look into ligaments, cartilage inside the knee joint, potential tendon problems, and we do that in order to ascertain whether the pain might be coming from one or from another structure, in order to be able to ask a surgical colleague to take over the management if we feel that surgery might have a role, investigate it further, or try and establish a more conservative plan of management that may involve several other non-operative techniques. We can supplement the findings from clinical history and from a physical examination with some imaging. And the imaging that we would request would be plain X-ray to assess the state of the bones in order to diagnose possible osteoarthritis, or if we suspect that the problem might be more related to the soft tissues within the joint itself, we can look into an MRI scan. The knee is in the middle of the leg. We've got the hip joint above, and we've got the foot and ankle below. So any pathology that affects the knee can potentially refer pain towards the hip or towards the ankle, more commonly towards the hip. So examination of the hip and the ankle to try and eliminate all the potential reasons for associated or related pains in those other joints might be appropriate as well at the same time. And the combination of those elements, the clinical history, the physical examination of the different parts of the leg, together with the imaging, will hopefully lead towards a final diagnosis.
And what are the possible treatments and medications that the London Pain Clinic can offer, and what are their benefits?
There's a range of treatment that we can offer at the London Pain Clinic. We can offer, following the initial assessment, physiotherapy, which can be combined with medication. The medication, depending on how we feel that the symptoms are related to a primary musculoskeletal, primary neuropathic, or the combination of both, might be down the route of an antineuropathic agent, or can be down the route of more over-the-counter type of medications, including anti-inflammatories, including paracetamol. Depending on how the symptoms have presented and for how long and what other options have been tried before, we may need to evolve into other types of treatments that occasionally from time to time may include opioid derivatives. The peculiarity that I mentioned earlier of the knee joint having such rich nerve supply means that two different topical treatments can be particularly effective with knee pain. One of them is capsaicin, and the other one is lidocaine plaster. Capsaicin cream is effectively a chili pepper derivative on a very mild concentration, and it has efficacy in the treatment of osteoarthritic pain and also neuropathic pain. It's applied 3 times a day for a period of 2 months and then discontinued. And whilst the only side effect that commonly appears is a burning sensation, not actual burning, but a burning sensation on the skin where it has been rubbed on, for the first few days, lasting probably half an hour, maybe 45 minutes perhaps, after each time that is applied to the skin, the chances of capsaicin cream resolving the symptoms are reasonably good. I would say probably about 30% of people who try capsaicin cream have a significant improvement that sometimes can mean full resolution of the symptoms. Lidocaine plaster is effectively a local anesthetic patch, probably about this size, that you put on the skin over the area where the pain is directly, 12 hours on, 12 hours off, and it can reduce the symptoms. So it can be useful for people who cannot tolerate other medication, or it can be useful for people who are not prepared to accept the side effects that can potentially be associated with other types of medication, and for whom surgery is either not an option or they don't want to undergo that type of treatment. It can provide symptomatic treatment, but it is very unlikely that they will resolve in the long run what the problem is. We can escalate towards more formal nerve painkillers or towards the different types of medication I described above, which often, when combined with physiotherapy, might be beneficial. The rationale to offer analgesics, painkillers, together with physiotherapy, is that physiotherapy on its own is likely to be painful. And if we can offer some form of reducing or relieving the pain before embarking into a physiotherapy type of treatment, the chances of benefit will increase. The engagement from you as a patient will also be higher, as you feel that you can tolerate the type of activity, the type of exercises with a bit more ease and with less disturbance from the pain. Other type of treatments that we can offer at the London Pain Clinic include injection techniques. We can inject different areas of the knee if we can find that there is a specific tendonitis or specific trigger area. Those areas can be identified with ultrasound, and a needle can be placed accurately in the area where the problem is and injected with an anti-inflammatory and some steroid. We can also modulate the nerve supply to the knee joint, which in cases of osteoarthritis or soft tissue injuries that are specifically painful, where the surgical treatment is either not available or not possible, either because the patient does not want surgery or because the patient is too frail to tolerate surgery, those techniques can be beneficial. Effectively, there are a significant number of nerves that supply the knee joint, and they emanate from the nerves that supply the leg, primarily sciatic, femoral, obturator, and their branches. The four major nerves from where the nerve supply to the knee joint will branch off are the genicular nerves. And the genicular nerves are four of them primarily. There are two above the kneecap, one on the inside, one on the outside, and two below the kneecap, one on the inside and one on the outside. We can access with a small needle each one of those nerves other than the one below the kneecap on the outside, because that one lies in very close proximity to the nerve that will supply the muscles of the shin and calf, and therefore movement for the foot and sensation for the foot. In order to prevent that potential damage to this specific nerve, we would avoid doing any interventions on this specific area, but the other three can be accessed from the front of the knee by placing small needles in these 3 points. This is done in an operating theatre with an X-ray machine and with a little bit of sedation intravenously, and it has efficacy for painful knees after a knee replacement or after knee surgery, but also for painful knees where surgery has not been carried out. The efficacy is in the order of 60 to 70%, and resolution of the pain can be immediate and fairly prolonged. I would say in average 3-4 months is a reasonable time expected, which we then tend to use as a diagnostic screening test to plan further treatment. Providing that there has been pain reduction for a period of time that has been translated into less painkillers, better quality of life, and more ability to carry out a normal daily living, we would be at the London Pain Clinic happy to progress towards further treatment within those nerves that may involve the use of radiofrequency techniques to provide a longer lasting lesion. These, in about 80% of the patients, will provide pain relief for a number of years. Pain at the back of the knee can be treated by modulating the nerve supply that is in the soft tissue, the spongy soft tissue at the back of the knee. And those nerves are accessed with the help of an ultrasound machine from the back of the knee, and they can be selectively injected there. Once again, the success rates would be similar, and the expected length of benefit would be similar. So, overall, the treatments that we would expect to be able to carry out and to offer you with knee pain would range from physiotherapy to injections, including medication. For the group of patients for whom there has been psychological effect as a consequence of the disability brought on by these symptoms of pain and the associated disability, we can also offer support by having appropriate psychological treatment.
Thank you. If you would like more information or you would like to book a consultation at the London Pain Clinic, then please visit the website at www.londonpainclinic.com.